Good afternoon. My name is Connie McLaughlin, and we want to thank you for joining us today for our webinar on the MUI Rule training for the direct support professional. We're glad that you could join us today and appreciate your time. Before we get started with the presentation, we're going to go through some quick housekeeping items. First of all, many of you have joined us in the past for other webinars, so we know you're familiar with the system. However, if you are new to the webinar system and you are experiencing some difficulties with sound, we ask that you turn off your computer speakers and listen only through your phone, or if you're only listening through your computer, sometimes it helps if you log off and log back on. If you continue to experience issues with the webinar, you can contact our office at 614-995-3810, and someone should be able to assist you. Today, we only have a short amount of time to go through a lot of material, but we'd like to keep this as interactive as possible, and we would encourage you to type in questions and comments as you have them. If we are able to get to those during the course of the webinar, we will certainly address those questions and comments then. However, if there's unanswered questions at the end, we will compile all of those and have our presenters address those and send them out to everyone that's attended the webinar today. Anyone that is participating live in this webinar today, which is on October 15th, 2019, will get 1 hour of continuing professional development credit. The email address that you provided, you will receive a certificate within 30 days. So if you have signed on to the system, you don't need to do anything further, and you're viewing through your computer, you will get credit. If you are participating in a group, which we know many of you are, please just send in the Excel spreadsheet, the group attendance sheet, and then you will get certificates for everyone that has participated. As I mentioned, we will be going through a lot of materials today. And so in terms of covering everything, we sent out the health and welfare alerts and some other material in advance, as well as the handouts. If you did not receive a copy of the handouts, you can download those from the handout section on the GoToWebinar now. Again, if you have any questions during this webinar, you can contact someone at our office, and the phone number is provided there for you. The health and welfare system in the state of Ohio is more than just a reporting system, and we want to make sure that everyone, especially the direct support professionals, know that their role in this process is critical. Whether something is considered an unusual incident or a major unusual incident, the work that you do daily to keep individuals safe and healthy and happy is critical. And so we thank you for your dedicated service to individuals. We know that the direct support professionals, or DSPs, are really the backbone of our system, and we could not appreciate them more for the work that they do. It's so important. Today we're going to talk about the following items. We're going to talk about the definitions for unusual incidents and kind of what's the difference between a UI and a major unusual incident, or a MUI. We're going to review very quickly the 19 different categories of MUIs. We're going to talk about patterns and trends. We're going to share some data from the previous year, which is always really insightful, I think. We're going to talk a little bit about the abuser registry, and then we're briefly going to go over those alerts that you've received that were emailed to you. Today, we're very fortunate to have 3 different speakers with us talking about the different materials today. We have Nick Pukwaziwa, who is an investigative agent at the Medina County Board. Welcome, Nick.
Thank you.
And then we also have Kathy Bline and Russell Blank, who are regional managers in our office. So welcome, Kathy and Ross.
Thank you.
And before we get started talking about unusual incidents, we're really just going to briefly go over this quality improvement process that we've discussed just a little bit. I think it's important to note, whether you're an individual, a family member, or someone that provides supports, whether you're a provider, an SSA, an investigative agent, that you know that all incidents that our individuals experience are important. They're just going to be handled a little bit differently. So if it's an unusual incident, the same actions are going to occur. Immediate actions are going to be taken to ensure that person's health and welfare. An investigation is going to be initiated. There's going to be causing and contributing factors identified and prevention plans put in place to kind of reduce the likelihood that that incident occurs again. If it's a UI, all that is done by the provider of service. If it's a major unusual incident, that whole process is going to be initiated by the county board or by the developmental center in which that person resides. So again, all these incidents are important. This is all part of a bigger process around quality improvement, and you all play a critical role in that. So I just want to, again, reiterate that this is all important. The work that you do every day really makes an impact, a positive impact on the individuals that we support. So I'm going to turn it over to Nick, and he's going to talk about unusual incidents at this point.
Okay, so unusual incidents are defined as an event or occurrence involving an individual that is not consistent with routine operations, policies, and procedures, or the individual's care or service plan. But this is not a major unusual incident. You can see here there's some examples of unusual incidents, dental injuries, falls, and injuries that are not significant, medication errors without a likely risk, overnight relocations, natural disasters, mechanical failures, rights code violations. If there's not a risk to the individual's health and safety, those are unusual incidents that need to be investigated as such. And then unapproved behavior supports, that can be, physical restraint, chemical, mechanical, without likely risk to the individual's health and welfare. Also emergency rooms. A lot of people go to the emergency room to get checked out. Those are not necessarily MUIs, but those are going to be unusual incidents. Once they get there, then we figure out, what the treatment is, or if there's an admission, for example. The programmatic implementation incidents, these are an unusual incident involving the failure to carry out a person-centered plan when such failure causes minimal risk or no risk. That is the key. When there's minimal risk or no risk, we're going to be looking at as a program implementation UI. And as you can see here, there's some examples. Lack of supervision for short periods of time. Again, that's dependent on the location. If it's a very hazardous environment, there's a good chance that's going to be an MUI. But if it's just very short periods of no supervision, at familiar places like home, day program, those are unusual incidents. Staff fall asleep for a few minutes, there's very minimal risk, and the individual suffered no adverse effects. Agency staff or anybody volunteering to provide transportation for individuals in a minor car accident. If the staff was cited but no one was harmed, that's part of the program implementation UI. So the incident report requirements, this is very critical for the beginning of any UI investigation or MUI investigation. Any person who provides services that's being paid or volunteering should document the report after making the report, making the necessary notifications, and that could be to emergency medical personnel, it could be to a supervisor, county board, etc. For the unusual incidents, the requirements are what happened, when did it happen, where did it happen, who all was involved, and if you know the why, we want to make sure that we include that. So when you're writing the incident report, focus on what did you observe. On this date, at this time, and you explain where you were, who you were with, what was going on around you and around the individuals that you're supervising or working with. The 13 required elements to an incident report, they include but are not limited to the name, date, location, and description. And we need the names of the people there. There's multiple staff, we need their names. And of course, the individual's name, we need to have that included as well. We want to, for the unusual incident requirements, we want to make preventive measures the most important part of that UI. Providers are required to investigate all unusual incidents and document the actions that were taken. Some immediate actions have to happen within seconds or minutes. Other parts of the immediate action could be a follow-up to what was done within those first seconds or minutes of that incident. We want to make sure we identify causing and contributing factors, and how we do that is we look at the who, what, when, where, why, and how. Those causing and contributing factors are going to give us the information we need to address in the prevention plan. Immediate actions, there's various immediate actions. Check the individual for injuries, call 911 if necessary before, if anything else needs to be done first, call 911, initiate first aid, contact the doctor, secure money. We want to make sure the individual's needs are met and as soon as possible. If they need emergency medical treatment, that comes before anything else. Comes before writing an incident report. Once you have time to slow down, you're no longer part of, taking care of immediate action. Then you get a chance to sit down and write your report. I believe I hear from a lot of providers, their best practices, they make sure the staff write the incident report before the shift is over. So then once you go home, you don't have to come back later and write it, because then, you've maybe slept or hours, or maybe, if you don't work for another 2 days, then, there's a lot of information that's missed there.
Excellent. We had a couple questions. I'm just going to address those really quick before we move on to the major unusual incidents. One of the questions had to do with, what if someone's seen in the urgent care or ER because their doctor's office is closed? Yes, that would still be considered an unusual incident because they are being seen by the urgent care or ER. And then the second question, we talked a little bit about 13 required elements of the incident report. And without getting into the list, you can find that in the rule or in the MUI UI fact sheet. But that's the name, address, the date of the incident, location, type of injuries, immediate actions, name of the primary person involved, statements, and further medical follow-up. And there's some additional things in there as well. But basically, those are things that you'll find on the sample unusual incident report that's available on DODD's website, and generally what we see when most agency providers have a standard incident report or a county board. So now I'm going to turn it over to Russell to talk about MUIs.
Thanks, Connie. MUIs, simply put, an MUI means alleged, suspected, or actual occurrence of an incident when there is reason to believe the incident has occurred or may have occurred. There are 19 categories. We're going to go over those throughout the presentation. But these can actually include whether or not you directly witnessed a particular incident, or whether or not an individual has told you information that may lead you to believe that it meets criteria for an MUI. Moving forward, we're taking a look at reporting responsibilities. Listed there, it states to take immediate actions to protect all at-risk individuals, which shall include the following. The key thing is, as Nick discussed earlier, immediate actions. What are we doing? How are we responding to the incident if it's an immediate response? And that can include ongoing medical care or any of the other examples that Nick discussed. But looking at this item B there, it may also include removal of an employee whenever there's an allegation involving physical abuse or sexual abuse. And this is will typically take place until the provider has reasonably determined that such removal is no longer necessary. If there's any question or concern there, typically it's encouraged for the provider to work with the county board to try and talk through any concerns as to when when that particular employee can or cannot return to work. Of course, at the bottom there, any discrepancies shall be resolved by the department. But just again, encouraging that dialogue between the provider and the county board to ensure that we're taking care of all individuals and their safety. And then any other necessary measures to protect the health and welfare of at-risk individuals. Reporting responsibilities. The list here are examples of when you're expected to report to the county board within 4 hours any of these MUI categories. That includes accidental or suspicious death, exploitation, misappropriation, neglect, any peer-to-peer act, physical abuse, prohibited sexual abuse, or verbal abuse. And the last one, whenever you have an inquiry from the media regarding an MUI, it's important that that's communicated as well. Now, bearing in mind, as what Nick indicated earlier, when discussing the incident reports, it's important that we are maintaining focus on responding to the immediate incident. It's not like we're looking for that 4 hours and 3 minutes and then all of a sudden we're concerned about a failure to report. No, we're really looking at being sure that we are receiving the information timely, but also looking at what the immediate actions and maintaining focus there. Some of the reporting responsibilities continued. The incident reports are to be submitted to the county board by 3 p.m. the next working day. So if you have an incident that occurs on Saturday, and the next working day is going to be that Monday, it's 3 p.m. that following working day. Indicate on those incident reports whether or not you contacted law enforcement whenever it's involving a criminal act or children's services. Those are key things, just clearly stating what exactly occurred, how we responded, who all was involved. It's typical that I personally, I don't know how you feel, Nick, but I'd rather have too much information than not enough, and then having to go back and figure out what exactly was done in response to the incident provided. Know your role in the process and what you should expect. So if you have any questions regarding this, communicate that with your provider, your supervisor, with the county board. Know what to do and what to expect if you're going to be, if you happen to be a PPI. That's understanding that in some situations, it's just part of the nature of the work that we do, that sometimes we do find ourselves as a PPI and understand that there's a process that has to take place and be maintained. Are you required to cooperate? And the answer is yes. Under all MUI, you are required to cooperate throughout the investigations, and it's again part of what's expected in order to ensure all health and welfare for not just the individual involving the MUI, but any and all other individuals that may receive services. Looking at the reporting rates, we have on this chart the reporting rates year by year, along with when the MUI rule changed, listed there. I think one was in 2008, and then another rule changed at the end of 2013, I believe. And then, of course, we had a new rule that just went into effect this year on January 1st. Taking a look at the MUI categories, MUI allegation categories, the following three have been the leading MUIs. Biggest one on the left there is going to be unanticipated hospitalization, followed by unapproved behavior supports, and then third is going to be your neglect category. Next, I believe I'm going to hand it over to Kathy here.
Okay. So I'm going to go through some of these definitions pretty quickly. There's several of them. I'm just going to kind of hit some highlights. I know Russ had made a comment about MUIs and what to do. As the DSP or the staff, whatever's happening, don't get so hung up on did something happen. Somebody reports something to you, whether it's a family member, you don't know, it's a third party. Don't get hung up on, I don't think it happened. Your job is simply just to report it and let the investigation happen. So that might help a little bit. As far as the physical abuse, this is physical force that can reasonably be expected to result in harm. Could be slapping, hitting. It does not have to have an injury. So we certainly don't have to have an injury in order to something to be physical abuse. Also note in this definition, there's nothing that talks about intent. Well, I don't think he meant to do it or she meant to. So there's nothing in the definition for intent. It's simply, did we use enough force to reasonably result in injury? And then also sometimes we see that people think, well, an individual was upset and started attacking, the mom or the staff, and then they reacted by punching the person or whatever. The rule doesn't talk about whether or not the individual starts it. That should not have anything to do with whether or not there was enough force, okay? Some of the contributing factors are control, maybe it's a caregiver burnout, maybe they're exhausted, lack of coping skills, things like that. In 2018, there was over 1,400 allegations in the state, 31% of which were substantiated. Physical or sexual abuse is the next one. Anything on unlawful sexual contact or conduct. A lot of times it could be power struggles, or maybe the PPI was a victim of sexual abuse themselves. Some of the contributing factors that we see. In 2018, a little less than 300 total allegations, and about 27% were substantiated. Verbal abuse, and this is one of the definitions where there is intent that we look at. The use of words or gestures or other communicative means to threaten, coerce, intimidate, harass, or humiliate an individual. So basically, the person is purposely doing these things for a reaction of some sort. Contributing factors associated with that, oftentimes their staff are in a challenging situation with little support. Maybe they don't recognize their own trauma history, or it could also be a control factor. In 2018, 743 total allegations of verbal, 46% were substantiated, and 49% of which the PPIs were staff. Kind of knowing the signs of abuse. As a direct support professional, you guys are out there in the trenches, so to speak. You know exactly the people that you're working with. So if you all of a sudden start seeing the individual, maybe there's some changes in their sleep pattern, they're dressing differently in layers of clothes. These are all signs of potential abuse. If they're withdrawing from normal activity or people that they normally like or like to be around. So just kind of being aware and report what you know. Maybe there's also some known sex or some new sexual knowledge that they're talking about. It's like, he or she's never talked about it before. So these are all little signs to kind of think, hey, something's different about this person. And like I said, you want to know that person a lot more than maybe a supervisor or somebody else. So don't be afraid to report. So what do you do if you think that maybe somebody has been abused? One of the big things as a direct support professional or who's ever receiving an allegation or you feel there's some kind of suspected abuse going on, it's really important that you don't try to prod and interview this victim. If this person is a victim of abuse, it's very traumatic, and we don't want to continually have that person be interviewed by 2, 3, 4, 5 different people before it even gets to the county board or to the IA. If you suspect it or it's been reported to you, stop and report. Don't get involved in being the investigator. So that will be happening later time. Also, it's really important not to blame the victim. It's very traumatic to be a victim, and some people automatically already feel they're in trouble, that they've done something wrong. So we got to be very mindful of that. When they are interviewed, we want to make sure we ask questions like, were you able to tell somebody? Were you able to tell him or her no, as opposed to why didn't you tell them no, or why didn't you report this? Because that's kind of blaming and makes them feel very scared.
And we know that the individuals that we support are 8 to 10 times more likely to be the victim of abuse than the general population, and that number just continues to increase. And oftentimes what we see is someone might be victimized multiple times within their lifetime by the same or different perpetrators. So it's really important to make sure that we're not only making sure that person is safe at that point, but making sure they get some long-term assistance to deal with that abuse.
Okay, neglect this year, the definition changed. It's still that you have to, the person, or there has to be a known duty to do something, and there was a failure to do that, that placed that person at a serious risk of injury or resulted in serious injury. And so that we kind of outlined a little bit more detail on what we mean by serious injury, resulted in treatment by a physician, physician assistant, or nurse practitioner. So we, this is where the program implementation UI came in, because there were some things that, the old neglect definition was kind of broad, and it kind of, painted a wide brush there, and we wanted to really kind of identify it. In 2018, this was before the rule change, was 1,800 roughly total allegations, and 67% were substantiated, most of which were staff, 85%. So I think this year we're about down 30% roughly on the neglect MUIs. So there are two types of neglect. It could be supervision or treatment. 731 of those MUIs were supervision, and as opposed to a little under 500 for treatment. What is the systems neglect? It could be a number of things. It could be multiple things that happened that attributed to the incident, and as opposed to one person or two people that knew they were supposed to do something and failed to do it. Sometimes it's systemically, it wasn't a good system to put in there. So some examples of neglect: an individual has a history of eloping, left in the car alone. Based on that individual, if that was a serious risk to that person, that would be an MUI. Maybe the diet requires all food to be cut in dime-sized pieces, and the staff gave the individual a slice of pizza. So we're really going to focus on neglect, and especially with the chokings and whatnot, and making sure that we're attending to that person's needs appropriately.
And the whole purpose of any MUI is really to work on prevention. So it's identifying what contributed or caused that incident.
We like to look at the transportation safety, and there were 142 vehicle-related MUIs reported in 2017. That equals about one every 2.5 days. And so that was an increase substantially from the year prior. These incidents are going to continue to rise that place people at significant risk. We want to look at whether or not the injuries resulted from people being unsecured in wheelchairs, they left alone in cars, being dropped off wheelchair lifts, things like that. To remedy it, we want to increase training. We want to increase the alerts. The ITS, incident tracking system, was modified so we can kind of collect better data on transportation-related incidents. We'll use this data to further increase our awareness. And I think Nick is going to cover misappropriation.
Yes, thanks, Kathy. Okay, so misappropriation. With intent to deprive, defraud, or otherwise obtain real or personal property, as prohibited in Ohio Revised Code 2911, 2913. So, for example, anything that belongs to the individual is theirs and cannot be used, borrowed, taken from. For example, credit cards, individuals' iPad, DVDs, anything that exclusively belongs to them. Borrowing individuals' money and then paying them back, withdrawing cash from their personal funds without their knowledge or permission. A lot of the causing contributing factors that we see is the staff has a gambling problem or a drug problem or any other problem that people have. People have issues with money or addiction. It's not just with our direct care staff, it's with anybody that works in the field, anybody out there, in the public. And multiple people having access to property or funds, or not documenting, transactions, can lead to misappropriation, easy access to the individual's financial information as well, like Social Security numbers, date of birth, etc. On the other side of finances, exploitation, unlawful or improper using individuals' resources for personal benefit, profit, or gain. So, for example, selling raffle tickets to individuals for your daughter's sports team, having the individual buy party items so you can get free stuff. I know one that we see sometimes commonly is staff taking individuals to the store, and then the staff using their own rewards card to benefit from that sale to rack up points. Having an individual do cleaning or any kind of chores or jobs, that's not part of their plan. Having the individual buy, a fax machine to use at home or for a business. So basically, what's in the individual's plan is to benefit them, and that's what should be followed. When you get outside of that, then you start to run into chances of exploitation. Prohibited sexual relations. When we get reports of any kind of sexual conduct or contact, we first look at those as abuse, because we don't want to overlook that. Any staff or volunteer that's working with individuals with disabilities cannot have a sexual relation with an individual unless that staff or volunteer is the individual's spouse. So anybody that's employed or under contract to provide care to the individual at the time of the incident, and then anyone in the developmental disabilities employee supervisory chain of command.
Okay, I'm going to cover failure to report. A DD employee, you're expected to report. If you fail to, let's say you know that there's abuse or neglect and you fail to report it, that's going to be a separate MUI. If you knew or should have known, there were some questions in the past where, well, let's say there was a physical abuse allegation, and then also we found out a staff failed to report. If the physical abuse is unsubstantiated, it has no bearing on whether or not the failure to report would be substantiated. It's solely, did you know at the beginning of the incident or event, or should have known, and you failed to report it, that's going to be filed. So failure to result in a substantial risk of harm would be important to pay attention to. In 2018, there was 168 failure reports, 71% of which were substantiated. So that's huge. That's a lot.
Can you give an example of like when failing to report something would result in a substantial risk of harm?
So you got me there. So let's say you have somebody that there was an individual at the day program reports that dad hits him. This individual is getting ready to board the bus to go home to dad. The staff who heard that, this is an individual that reports this all the time, I don't really know, and they let the individual go home. So the problem was there was still contact with the individual and the PPI, and we didn't do anything to mitigate his risks. So there was a failure to report MUI as well as a physical abuse MUI filed in that case.
And regardless of what time has passed, if you know something, please say something. If you don't be so concerned about it's going to be looked at for failure to report or not timely reporting. We want to make sure we get that information as soon as possible. And oftentimes you're the one that's hearing or seeing something that could help us make sure that person is kept safe while this is being investigated.
And also to go with the failure report, I just wanted to throw in there, the documentation and the reporting should go hand in hand. So when you're reporting something to a supervisor or a manager, some type of documentation should be done on the part of the staff to follow up on that, or if it's writing something up and then if there's time to write it up first and then get it to a supervisor or a manager or somebody, because there's a lot of situations we run into where, we get into MUIs and staff say, well, I told the supervisor this or I told the manager that, and there's like no documentation, and the manager says, well, I don't have anything in writing. I don't have any reports or anything. So we just want to make sure that verbal reporting and documentation are done to cover all bases.
Good point.
Okay, the next definition is rights code violation. At MUI level is it violates the individual's rights and it places them at a risk of health and welfare. Example could be, let's say the individual was going to the movie, or you wanted to take them to the movie, he didn't want to go, became upset and started banging his head against the wall. That would be rising to the level of MUI. If there was an individual that was taking magazines to work and you took some magazines from that person and they never escalated to a point of being at risk of injury, they just got upset perhaps or stormed out of the house without any risk, then that would be a UI. But for the MUI-wise, we have to look at what right violation caused that person to be at risk. So we want to look at things like that. Peer-to-peer. So this is we try to really simplify this. It no longer was there, were they, intent to hurt, were they firmly fixed, all that. So basically, there are peer-to-peer means two or more individuals who are being served or involved in some sort of an act, whether it be exploitation, theft, physical, sexual, or verbal. Peer-to-peer acts, so the theft is there's intentionally trying to deprive the person of at least $20 or more of value or a significant value to that person. So the $20 is only for peer-to-peer. It's not for regular theft or misappropriation. Sexual act means sexual gratification. Sexual contact for the purpose of sexual gratification without the consent of the other. We want to make sure that person, if the one of them is consenting, the other one thinks they're consenting, we have to make sure that they are able to consent. Verbal act, purposely using words or gestures to intimidate or threaten or coerce another individual, and there's opportunity and ability to carry it out. So if somebody says, we might have in the past filed where I might have called Russ ugly. He's not, but let me say I call him ugly. He got upset about it. Well, that's not really a peer-to-peer verbal anymore. But if I say I'm going to take a knife and stab him and we live in the same house and I have access to knives, then that's something different. Exploitation means the unlawful or improper act of using an individual for monetary or personal benefit, profit, or gain. Physical acts, this is very basic. So it means a physical altercation that resulted in an injury that's treated, an examination or treated by a physician assistant or nurse practitioner. Involves strangulation, bloody nose, bloody lip, black eye, concussion, or biting that causes the breaking of the skin. Or the individual, one of the peers is arrested, incarcerated, or charged. So don't worry if they didn't mean to do it. So if somebody is putting somebody in a headlock, that's automatically going to be an MUI for a peer-to-peer. We want to look at, is it, obstructing the windpipe, things like that. Unapproved behavioral support means the use of prohibited measures. When the use of the prohibited measure or restrictive measure does not result in a risk to the individual's health and welfare, it will be a UI. So if we have behavioral supports, people will go through the Human Rights Committee, behavior support committees, and the team, and they're addressing certain risks. They're going to put something in their plan that we can do a behavioral support under certain circumstances. If for some reason that a behavioral support was utilized and it did not meet whatever the plan states, and it placed that person at risk, if there's any kind of resistance from the individual, we're going to consider that a potential risk. Holding someone's hand down and they're not moving it is not going to be a risk. And if I'm holding your hand down and you're thrashing around trying to get loose, then there's a risk of potential injury. The top 3 MUIs between 2016 and 18 was neglect, the unapproved behavioral support, and unanticipated hospitalization. Prone restraint. We are not to do that anymore. That's against the law for us to do it. Prone restraint is a method of putting a person's face or frontal part of their body in a downward position, touching any surface for any amount of time. It's prohibited in Ohio. Let's say that you're involved in a restraint and it's you're applying it, maybe a basket hold, for example, and it's approved, or you're doing it properly, and the individual goes to the ground and they lay on their stomach. You have to immediately let go and do not make any contact with that person. So you want to be cognizant of what's happening in the environment, and so that way you're not placing that person at risk. They could, they have been fatal. So we want to make sure we're very cautious of that. In 2018, a little over 2,000 UBSs were reported. Physical restraint was the most utilized one, and most of the restraints were done without any injury, so that's showing good training, and the staff is providing, the management is providing the training, and the staff is utilizing it, so that was very good.
Okay. One of the 19 different MUI categories is death, and we have two different categories of death that are considered MUIs. The first is accidental or suspicious death. Obviously, that could be anything from a car accident, it could be a homicide, a suicide, all those things. A choking-related death would be considered accidental or suspicious. A death other than accidental or suspicious is something we'd be considering like a natural death. Someone, was in their late 80s, which we see more and more than we ever had before, and they may have died of a cardiac-related medical condition, but that's considered natural. Of those two different categories, we have around anywhere from 800 to 900 deaths a year, which you consider we serve anywhere from 93 to 95,000 people in the state of Ohio. The leading causes of accidental death by far are fall, choking, drowning, and vehicle-related. We have seen an increase in attempted suicide that we're going to talk about next. And what we're seeing really kind of mirrors what we're seeing with the general population, just this kind of feeling of hopelessness. And so we're seeing increases in attempted suicide and also deaths by suicide. An attempted suicide MUI is one where there's a physical attempt and it results in ER treatment or inpatient hospitalization or hospital admission. And that could be a psychiatric hospital admission or actual, they're going and being seen for their medical, for an injury that resulted as a part of that attempt. In 2018, we had 146 attempts, and unfortunately, 5 people lost their lives. When you look at the long-range data analytics on this, it's kind of surprising. Back in 2012, we had no individuals die by suicide, and our rates of attempted suicide were very low, at about 50 each year, and we've almost tripled that in the last 5 years. So we encourage people to take every threat or any claim that someone's going to harm themselves very seriously. We just did a health and welfare alert on suicide, and we know that you received that as being part of today's webinar, but we want to make sure that you take every threat seriously, that you get people the help that they need. Don't just brush that off and say, oh, that's something that Nick says all the time that he's going to hurt himself, because you never know if that one time that person says that will be the time that they try to take their lives. We are seeing a correlation between individuals with autism and higher functioning individuals and the rates of suicide. Sometimes what we'll see is people have this, obviously they have a lot of prevalence with mental health disorders, but also have some issues with communication and being understood. And so, again, please review that health and welfare alert and make sure that you're looking at all the risk factors for the individuals that we support, and also gives you some resources on how you can support people to come up with safety plans and make sure the team is aware of what's going on. For missing persons, that's an MUI when it's not considered neglect, but the individual's whereabouts are not known after, a search of the immediate area has been checked, and that person is believed to be at imminent risk, or others around there may be at risk. And so, if there's an individual that maybe is not safe when out in the community and they go missing, maybe they're not safe around bodies of water, and they have run at the park. That might be considered a missing person MUI. We're going to do everything in our power to make sure that that person is located safely. We do see this happen where people go missing. Sometimes it's more a refusal of service, so make sure the team is aware of what's going on with that person, but certainly report that missing person MUI if this meets the criteria here. Last year we had about 475 cases where individuals went missing. A couple of those cases did result in an individual end up passing away. For significant injuries, that's when there's an injury of known or unknown origin. That's not a result of abuse or neglect, and it results in a concussion, a broken bone, dislocation, second or third degree burns, or requires immobilization, casting, or 5 or more sutures. That could be stitches. And probably the most significant classification of significant injury we see for known injuries is by far falls. You can see here on this chart that it's overwhelmingly the largest category of significant injuries that we see. We saw in 2018, but every year. It resulted in about 700 of the 1,400 significant injuries, so that's almost half every year that we see. The next slide just really goes over not only how many significant injuries we had, but how that looks proportionately to the number of significant injuries. So we have fall-related injuries versus total number of reports. And you can see it's between 45 to 50% every year. More importantly, we see a lot of fall-related deaths, and 18 was the biggest year we've had with 11 fall-related deaths since 2010. We know that the individuals that we support have some serious medical conditions, may need some assistance with mobility, and may also require some adaptive equipment to safely move and be transported. So it's really important, if that person that you're working with has a risk, that you're allowing the team to be aware of that you're working with the team to provide the best level of supports so that that person can be safe. We've worked a lot with the Department of Aging and the Steady U initiative. There's a lot of great resources in the Health and Welfare Toolkit on our website, so we encourage you to look into all of those things when you're able. Next, we're going to talk about medical emergencies. Every year we have between 600 and 700 medical emergencies filed each year, and a medical emergency is defined as when there's some life-saving measure that's taken with an individual. That could be CPR, it could be choking relief, it could be the use of an EpiPen, a defibrillator, and we're also considering Narcan as one of these life-saving techniques. We give you some data here from 2018. As you can see, choking-related interventions are by far the greatest number of life-saving measures that we use. And you can see that there was 104 back blows and about 277 times that abdominal thrusts were implemented in an effort to save someone's life. We focus a lot around choking prevention. As you can see, we've done very in-depth studies on what people are choking on. By far, peanut butter and hot dogs, those kind of things are the items that people choke on the most and have for the last decade. But you can see every year we have around 300 or more times that we will file a choking med emergency. That means that around 300 to 400 times someone's life is being saved. Unfortunately, you'll see that there's been a trend, at least from 2006 to 2018, 2018 being our most difficult, hardest year, where we had 21 people lose their lives based on choking-related incidents. And that could be that, someone was given the wrong diet texture. It could be that they grabbed someone's food, they had pica, and they shoved something in their mouth, blocking their airway. So we always want to take those things very seriously and make sure that we're supporting people in the way that they need and following their plan. We're very, very pleased to announce that this year we've only had 3 choking-related deaths thus far, and we're in October. We're really happy about the work that you've done, educating your staff and becoming more informed on supports and prevention around choking. Just to hit this really quickly, we want to make sure that we're addressing choking prevention and assessments and evaluations through team discussions, training, and communication. There's a lot of resources on the in the health and welfare toolkit. We're going to hit really quickly unanticipated hospitalizations. It's important to note that this definition has changed with the 2019 rule revision. So unanticipated hospitalization is any time that someone is admitted to the hospital or there's a hospital stay that is over 24 hours that is not pre-scheduled or pre-planned. There's also a provision where if someone has a chronic medical condition and certain criteria are met, that can be included in their plan. In 2018, these are the reasons that people were hospitalized medically. We also have psychiatric hospitalizations, infection and pneumonia. Hi, it appears that we've lost audio. Can everyone hear us now? Okay, so I'm going to have Russ talk about law enforcement MUIs.
Okay, sorry about that. Yes, in regards to law enforcement MUIs, simply put, it's whenever an individual is charged, incarcerated, arrested, or tased, even if the individual is not arrested. So those taser incidents are not very common, but whenever they do occur, it's something that we're interested in hearing about. Rather quickly, two exciting areas that DODD has kind of taken a part in being a part of the planning and implementation of our, one was in trauma-informed policing that involved basically it's a new training curriculum for any law enforcement officers out there that they will have some sort of trauma-informed care approach or training around that. And it's sort of just an additional information and education that will better help our officers serving in the field, work with also individuals with intellectual or developmental disabilities. Next was a House Bill 115. That's the Communication Disability Act that's now in, it's now law. And this is a voluntary system where any person with an communication disability can voluntarily enroll themselves in a into basically it's a LEADS, which is Law Enforcement Agency's database system. It's a communication system. Basically, whenever you see police officers in their cars in the computer, and so whenever someone who has a communication disability is stopped in a vehicle or someone is traveling with someone, if their information is ran, it will indicate that they do have a communication disability. This is something that's new within the last year. For further information, I would go to Opportunities for Ohioans with Disabilities, their website, or you can always contact us directly, and we'll be able to redirect you to how to find out additional information there. Moving on to the abuser registry. The abuser registry is, it was established under Ohio law, and it's a registry that lists people who have committed certain acts of abuse, neglect, misappropriation, failure to report, and or prohibited sexual relations. So this does not mean that everybody who has a substantiated MUI will be placed on the registry. It's with those significant incidences with a significant risk of health or welfare that it stands out beyond most other MUIs. What this list does is it prevents any person on the abuser registry from working with other individuals in the field. As of a few days ago, on October 10th, there were 953 people on the registry. Sort of the process for the abuser registry. MUIs are closed out, and if it's substantiated, it's then reviewed by a regional manager who then forwards it on for additional review to determine whether or not it fully meets criteria and should be assigned to a registry investigator. From there, it's assigned to a registry investigator who then we request the file, they review the entire file, and if it should move forward, it then will go to an external committee. The external committee makes their decision, and then after that, there's due process further that allows for a 119 hearing. A 119 hearing is essentially the opportunity for that person to state their case as to why they should not be placed on the registry, and then after that, it's the final decision is then made by the director here at the department before going on the abuser registry. And briefly here, this is the essentially the pyramid for the standards of proof. At the bottom there, we have preponderance of evidence for which is required for substantiation. That means it is more likely than not to have occurred. And then we have for the registry, clear and convincing. Somewhere between clear and convincing is somewhere between that and what's required for a criminal conviction, which is reasonable doubt. And that piece there again is, even though something may have occurred that for whatever reason did not result in criminal charges, if it's significant enough, there can still be placement on the registry to help protect individuals that we're serving. And moving on, I think I'm going to pass this over to Connie here.
Okay, and you've all received a copy of the health and welfare alerts, not only for 2018, but 2019. As any DD employee, you're required to review and be trained on all of these alerts. I know in Kathy's section, she specifically went through all these different, the things that might be red flags to abuse. And so that covers much of what's considered in this alert. I would encourage you to look at the alert that was emailed to you and to click on the video with Dr. Caldera. She talks about the different types of abuse, some really good information here, most of which we've already highlighted in our section on physical, sexual, and verbal abuse. Again, preventing choking is a priority for all of us that work with individuals with developmental disabilities, and we can't encourage you enough to view this video that highlights the good work of Tina Brown, who is a direct support professional, and how her actions saved multiple people's lives. But again, we want to have you focus on prevention. What can we do to address people's risks up front before something happens, but also making sure that we provide good, timely medical care and interventions when someone is experiencing any kind of choking incident, and know the signs. You know, their face turns red, their lips turn blue, maybe there's food spilling out of their mouth. Sometimes people act panic and may leave a room Don't allow someone to be alone if you feel like they may have experienced some kind of choking. Summer safety, obviously we're on the outskirts of summer here, but one thing we can't reiterate enough is car safety. Leaving people in vehicles in warm weather is dangerous and often deadly. So please make sure when you're working with individuals that you don't leave people unattended in cars, that you make sure that they're hydrated, and make sure you take into account things like drowning and people's water safety. Seizure management is an issue that is something that we work with a lot of the individuals that we serve that may be diagnosed with epilepsy. And as direct support professionals, you should be aware of the different types of seizures. And also, you can watch this video by Karen Brown with the Epilepsy Association. And I think she points out some real risk factors for the individuals that we support. Unanticipated hospitalization, we've really already talked about this, but it's really making sure that when you take someone on a doctor's appointment or to the hospital, that you make sure that you're able to communicate that person's signs and symptoms, how long they've been ill, provide critical information like allergies and things like that. Make sure that the person has any kind of comfort items to keep them somewhat entertained and comfortable while they're waiting in any kind of hospitalization, and just make sure you're aware of the different types of hospitalizations that we review today. Finally, preventing flu and pneumonia. We're going to be putting out an alert here in the next several weeks to talk about preventing the flu and pneumonia. And this year, I think they're encouraging people to get their flu vaccines by the end of October. So if you can make sure that people that you support that are risk for flu or pneumonia are getting the needed vaccines that they need, please talk with their primary care physicians to make sure that they are supported in those areas. We're not going to go over the rights, but we want to make sure that you review them as part of today's webinar. And we do have some questions. However, our time has passed. We're happy to take a couple of these if people would like to stay on the line. For those that you need to leave the webinar, we completely understand, and we apologize for the issue with the audio. However, if you have participated in the live webinar and you've logged on your computer, you will receive a certificate from us along with some additional information. If you are participating in a group, that means more than just you, please make sure that the group attendance sheet is typed into the Excel spreadsheet and that's forwarded to our office. You have all our contact information here. Again, we can't thank you enough for the important work that you do as a direct support professional. You really are the backbone to the system of health and welfare and quality supports to individuals that we support. So if you need to end the webinar, we understand. We're going to take 5 minutes to address some of the questions, and then we will compile all of these and provide them to everyone that has joined us today. So thank you for your time and attention. And I'm going to go through and ask some of our presenters these questions. So Kathy Blind, your question is, would every peer-to-peer act be an MUI?
No, it won't. So you want to go back to that definition of peer-to-peer. Let's say it's a physical. If I am a peer and Russ and I are living together and I slap Russ on the arm and he doesn't go to the hospital, get treated, then it's going to be a UI. So we just want to look at that definition and make sure that any of those criteria meet to know if it's an MUI or not. If I punch him in the nose and he gets a bloody nose, then it's going to be an MUI because it's the location of the injury is the head and face area. We want to focus on that because that's where your brain is. So.
Right. And we can't underscore enough, there's a lot of resources available on our website. So if you go to the Health and Welfare Toolkit, you're going to see things like a frequently asked questions, an interpretive guideline, an MUI, UI fact sheet. All those are resources that have been developed over the years to help you understand what your requirement is as a provider, what your requirement is for a direct support professional in reporting, and kind of talks about the different processes. However, if there's ever a question, please don't hesitate to call your county board partners. They're there to support you and provide information. You also have our information. You can contact us. This slide that we're on right now talks about the different contacts for the county boards. Those are available on our website. So anytime you have a question, there is someone that is available. If it's an MUI-related question or a concern, there's someone available to help you. So don't forget about those resources. The next question talks about if there's a risk of a client refusing and creating an MUI during a fire drill, and I'm not so certain I understand that. So, you know, let's say that I know when I used to work in an intermediate care facility, we'd be required to do fire drills in all different shifts. And let's say an individual is walking by another peer and smashes his head against the wall, causing a concussion or, you know, some significant injury to that individual. Regardless of whether there was intent or not, that would be considered a peer-to-peer act for a physical act. But I'm not sure I completely understand that. So does anyone else want to take a stab at that one?
The only thing I could maybe think of is if there's any sort of obstruction during the fire drill, considering that it's a drill, that it's just that, it's a drill to see how everyone responds to that particular incident should there be an actual fire. So it really depends on what specifically is occurring there for us to be able to determine whether it's an MUI or can be considered as just a UI. Again, that's a situation where I would encourage you to, if you think what's present may actually be an MUI, go ahead and report it to your county board, and they'll reach out and follow up and perhaps have additional questions, or may be able to immediately determine whether or not it is or is not an MUI.
Okay, thank you. There were some questions around exploitation when we talk about utilizing someone's like grocery card. So we would say that if an individual is shopping all the time at one store, that's their preferred store, that they go ahead and enlist in whatever, you know, points, perks program they have there. We're not going to necessarily file an MUI if we find out that Russ used his Giant Eagle card to get the individual some discount, but we would certainly discourage that. Where we're seeing that more concerning is, you know, if you're using someone's, if you're having an individual buy things at a certain store so you can get a benefit from that, like you get a, you know, a check or Kohl's cash or something like that. We see that more of a concern with exploitation. But certainly, as with anything, consult with your county board. And I think that gets to the majority of the questions, but we were going to go ahead and wrap up here, compile all those questions and any other resources, and we will send that out to everyone that's attended today. We can't thank you enough for your time and attention today and your dedicated service. So this concludes today's webinar. This will be posted on the website probably within the next week. Thank you very much.